Hello, welcome class. My name is April Drosis and my presentation today is on chronic obstructive pulmonary disease. It's such an important topic because we will see it quite frequently in the primary care setting. So what is COPD? COPD is referred to as an inflammatory respiratory disorder that's typically characterized by the presence of airflow obstruction, meaning they're having difficulty exhaling or getting the air out, due to chronic bronchitis or emphysema. More than 16 million Americans are diagnosed every year with COPD. 160,000 deaths per year have been documented related to COPD. So that actually makes it the fourth leading cause of death in the United States. There are structural changes that happen within the lungs with COPD. Typically, the bronchioles are where the site of obstruction is, and then the alveoli can be affected and have impaired gas exchange, and then also develop thickening of the walls and have tons of thick mucus. On the previous slide, I discussed the structural changes that happen within the lungs. This picture will give you a better understanding of what's actually going on. So all the way to the right on the bottom is a picture of like the bronchioles where you can see that the walls are thickened and the mucus is thicker, pretty thick, so that the airway is narrow, and that makes it more difficult to breathe. And then in the middle are the alveoli or the air sacs, and you can see how they're damaged. And also that's what causes impaired gas exchange. So this is what's going on within the lungs of a COPDer. So patients with COPD, what would the symptoms be when they present to the clinic? They may have shortness of breath, be tachypnic, breathing very shallow, increased coughing. They may have increased sputum production, typically yellow, could be green, tan, or blood tinged. Their O2 sats are typically lower too, like between 88, 90. Wheezing or feel that feeling of chest tightness, so they may be having a COPD exacerbation. Some of the risk factors include being over the age of 65, also being of male gender. I think it's like about 52 or 53% compared to women. Cigarette smoking, reduced lung function, or having any other type of lung issues, air pollution, and then alpha-1 antitrypsin deficiency is a protein that the liver is synthesized in the liver that actually protects the lungs. And if you're deficient in that, you're subjecting yourself or putting yourself at greater risk for having damage to the lungs by irritants like smoke, dust, or air pollution, something like that. Okay, so a patient presents to the clinic with complaints of shortness of breath, coughing, increased sputum production, and then they do have a history of exposure of disease factors. So that may include being over 65, maybe they have the alpha-1 antitrypsin deficiency, or they have other lung issues going on. So in order to actually diagnose COPD, they have to do a forced spirometry. So the forced spirometry is actually a ratio of FEV1, so that's the forced expiratory air, how much air they can get out of their lungs within 1 second, divided by the forced vital capacity. So that is the total amount of air exhaled after maximal inhalation and forced exhalation. So the two divided are expressed in a percentage, and then that percentage has to be less than 0.7 in order for the patient to be actually diagnosed with COPD. Of course, you can order a chest x-ray for a patient that's having shortness of breath, or your thinking that it may be COPD, but you cannot actually diagnose COPD with a chest x-ray. So you would have to do, as mentioned on the previous slide, the forced spirometry. Patients that have had confirmed COPD and there's things going on, or even just for screening, you can order a chest CT. The Global Initiative for Chronic Obstructive Lung Disease puts out a gold report that has treatment guidelines. This little chart here shows you the severity staging. So gold 1 all the way through gold 4, and then mainly looking at the forced expiratory volume in 1 second. So I thought that was pretty interesting. So less than 30% of the predicted, or FEV1, is very severe COPD. So now your patient's been diagnosed with COPD. How are you planning to treat them? This really easy to use assessment tool called ABE is basically grouping your patients into one of those groups. So either group A, group B, or E. A is stable management. So they've had 1 or no moderate exacerbations in the past year and they have not been hospitalized. There's 2 tests that they can take and score. The COPD assessment test, or the CAT score, of 10 or less groups them in A, and also the medical research counseling score, ranging from 0 to 1, will also put them in group A. And at that point, the patient, you can start them with a short-acting or even a long-acting bronchodilator. So the short-acting bronchodilators are your albuterol or ipratropium bromide, and the long-acting bronchodilators are your Symbicort, Ceravent, Advair, those kinds of things. You've gotten that complete history on the patient and you're utilizing the ABE assessment tool. They've said that they've had 1 or no moderate exacerbations in the past year. They've taken the CAT score and the MRC score, and they've met the criteria for group B. So now we're going to start treatment. We're going to look at the treatment guidelines, and the gold standard, or the gold 2024, is to do a LABA and a LAMA. So the long-acting beta agonist and the long-acting muscarinic antagonist, or the anticholinergic, like your Spiriva. So you'll start the combo LABA and LAMA. If for whatever reason they can't do both together, typically the LAMA is recommended over the LABA because it controls the exacerbations and the symptoms better. Your patient has had 2 or more moderate exacerbations in the past year, and that has led to at least 1 hospitalization. So you're already going to do just like you did in group B. This is group E now with the moderate severe COPD patients. You're going to do the LABA plus the LAMA, and then typically their eosinophils, if they're greater than 300, you're going to go ahead and you're going to start that corticosteroid. So then it'll be LABA plus LAMA plus your ICS, or your inhaled corticosteroid. How would you treat the patient that comes into your clinic that is already on a combination therapy that includes a LABA, a LAMA, and an ICS, and they're still having exacerbations? Where do you go from there? If you haven't already done so, referring to pulmonology would be the next step. You want to collaborate with pulmonology to figure out the most optimal treatment plan for this patient. They may start the medication roflumilast. Roflumilast is a phosphodiesterase inhibitor, or PDE4 inhibitor. And what this medication does is it has some anti-inflammatory properties that have been shown to improve lung function in patients with severe to very severe COPD. This medication is not a bronchodilator, and it also does not help with acute bronchospasms. So other things to consider with this medication would be if the patient is a female that is trying to get pregnant, or is already is pregnant, then it would be contraindicated. Number 2, your methylxanthine or your theophylline, which is not as widely used as it used to be. It does have a very narrow therapeutic index, and it also interacts with quite a few different medications. Some of these medications, like your metadine, your ciprofloxacin, erythromycin, and your beta blockers. And then number 3 is your antibiotics. When to consider using antibiotics. So typically the patient would come in with dyspnea, may have increased sputum production, but the big thing is purulent sputum. So if they're having those 3 things, especially, you want to treat for the organisms that are listed next to antibiotics. Typically, that would be your beta-lactamase or your augmentin, your macrolide, which would be azithromycin, tetracycline or doxy is another one that you can use. So those are considerations for when you think the patient's having an acute infection. Also, maybe tapering back on the ICS, that could help as well, and then the referral to see what pulmonology has to say. Why is patient education so important with COPD patients? Well, working in primary care, we're probably going to see quite a few patients being discharged from the hospital that need follow-up care for having a COPD exacerbation. What would be our biggest goal for those patients? It would be to decrease their chance of being readmitted to the hospital. And how do we do that? We educate them. So what things do we want to educate these patients on? We want to teach them what COPD is, what causes it, what triggers it. Do they know what medications they're taking? Do they know what they're used for? Do they know how to properly use them or take them? Do they know the side effects or when to call the office? If they're using an inhaler, teach back method is the best way to ensure that they know how to properly use it. Also, changing healthy lifestyles. If they're smokers, we want to encourage them to quit smoking. If they're overweight, we want to encourage them to lose weight, increase their physical activity. Also, it's really important to encourage them to stay up to date with any kind of vaccines because they're more at risk for developing lung infections. So, it's really important with their flu vaccine and the pneumonia vaccine that the patients know why they should get it and why it's important to stay up to date. Follow-up care is essential for these patients. Continuity of care is going to improve not only the outcomes for these patients, but patient-centered care is going to help with compliance. So you want to include the patient and have an action plan so they know how to properly manage their disease. Education is so important for these patients. We don't want them to get readmitted to the hospital or end up in the hospital for things that they just didn't know how to do or didn't understand. So education is so important. Some key points that I wanted to reiterate include early diagnosis of COPD is of utmost importance to improve patient outcomes. Forced spirometry is the gold standard for diagnosing COPD. So that's going to be your ratio of FEV1 divided by FVC. And if your patient is less than 0.7, then they have COPD with other symptoms. You're going to use the GOLD 2024 as your treatment guidelines. The ABE assessment tool is going to classify your patients by severity and help you order the medications for appropriate treatment. Education is going to be key in teaching patients how to use inhalers properly, what signs and symptoms to look for, and when to call the office. When are you going to refer a patient? Well, that's going to be if you're still having exacerbations and they're on combo medications. Follow up also, you want to closely monitor these patients, ensure that they understand and are compliant with their medications. In conclusion, continuity of care plays a crucial role in the early detection of exacerbations, contributing factors, or coexisting health conditions, while also improving self-care and compliance. This can result in decreased hospitalization rates and associated costs. The main pharmacological treatment for COPD relies on inhalation devices. To improve adherence, it's important to routinely evaluate inhalation technique, usually about every 2 months, along with adherence levels during each visit. Implementing a patient-centered care model allows for a customized approach to educate patients about their condition and treatment, manage it effectively, identify any potential problems, and know how to approach them. I appreciate your time watching my presentation. Thank you and have a great day.